Welcome back to the Deep Dive. Our mission here, as always, is pretty simple. We want to give you that high-yield, crystallized knowledge you need without, getting buried in all the minutiae.
Right.
And today, we are taking a scalpel to one of the most critical fields in surgery.
We really are. We're doing an operative deep dive, translating some incredibly dense, practical surgical knowledge into digestible steps. It's really designed for the junior professional. Our source material is the ENT and head and neck procedures, an operative guide. It's a consensus manual from George Makloulis, F.K. Seymour, Joanna Stevens, and a whole team of contributors.
And this book is just fascinating because it almost completely skips the why and jumps straight into the how. This isn't about pathology or the basic indications. This is a pure, pragmatic instruction manual. It's for the junior trainee on execution. So our goal today is to pull out the essential precautions, those critical high-stakes details, and the indispensable surgeon's tips from 41 core procedures. We're covering otolaryngology, head and neck, and facial plastics to give you a real shortcut to understanding the operative mindset.
Exactly. The authors are very deliberate about this. They focus purely on tried and tested techniques, on meticulous execution, because, at this level of training, that execution is it's everything. And to really emphasize the responsibility that's involved, the entire guide is structured around risk awareness. It all starts with what is probably the most crucial document of all.
The preoperative consent table.
Yes.
And for a trainee, that table is completely non-negotiable. It's like a rapid checklist of the absolute essential complications that must be discussed before the operation. It's the ultimate check for the highest risks.
And what's so fascinating is how dramatically the neurovascular risk profile shifts as you move across the head and neck. In otology, for instance, the risks are all about microscopic precision, about those deep neural structures. So, if you're discussing a stapedotomy or maybe a complex mastoidectomy, the high-stakes complication you absolutely must highlight is always facial nerve injury.
Right. It's all about that fine motor control. And even for a procedure that seems routine, like a myringoplasty, just repairing the eardrum, you still have to counsel the patient on alteration in taste.
Because of the chorda tympani nerve?
Exactly. The risk of handling it, its proximity. It's a must discuss.
Then you move over to rhinology, and the risks, they kind of move outward and upward. You go from nerves in the middle ear to these anatomical boundaries separating the nasal cavity from, the cranial cavity in the orbit.
So now we're talking about basic issues like septal perforation, sure, but also catastrophic events. Things like a CSF leak or visual disturbance, which are linked to procedures getting close to the skull base, like FESS or a lateral rhinotomy. And then when you get into the major head and neck operations, it becomes an outright neurovascular minefield. You're dealing with major nerves for movement, for speech.
And the book lists specific, named nerve injuries. So for procedures like a thyroidectomy or, say, a pharyngeal pouch repair, the big risk is recurrent laryngeal nerve, or RLN, injury.
And what about something like gland removal?
Right. So if the operation involves removing deep glands or large amounts of tissue, like a submandibular gland excision or a big neck dissection, you must discuss marginal mandibular nerve injury. And for any work in the posterior neck, the risk shifts again, this time to the accessory nerve, that's cranial nerve XI, which controls your shoulder function. So just understanding these mandatory consent risks, it shows you precisely where the highest surgical responsibility lies.
Okay, let's unpack that precision then, starting with otology. We're talking about procedures done almost entirely under a microscope, where the difference between success and a catastrophic complication is literally micrometers.
Absolutely. Let's start with the simplest one, grommet insertion from Chapter 1. The technical steps are pretty straightforward, but the guide gives you these crucial safety flags. For instance, if you're operating on a patient with Down syndrome, you have to take extra care with positioning the neck. And that's because there's a higher incidence of atlantoaxial instability. That's a mandatory pre-procedure safety stop.
And I imagine the practical tips for preventing post-op issues are just as critical.
Oh, precisely. Here's a micro detail for preventing complications. The guide specifically warns you not to touch the myringectomy edges with the suction tip.
Why is that?
Well, if you scrape those delicate edges, you risk bleeding right away, and then later on, tympanosclerosis. That's the formation of these dense white plaques on the eardrum, which can actually impair hearing in the long run.
That is the very definition of high-yield knowledge, a tiny action with a serious long-term consequence. So moving on to myringoplasty, repairing the eardrum. The guide mentions using trigall and conchal cartilage as bitter graft materials.
Yeah, as superior alternative grafts, you use them when a much stronger reinforcement of the tympanic membrane is needed, over the standard fascia graft. And the technique for elevating the tympanomyoidal flap is also highly specific for safety. The critical instruction here is to start the elevation of the annulus in the postero-inferior quadrant,
Okay, why there specifically?
because starting there lets you actively avoid damaging the ossicular chain, which sits deeper, and also the very sensitive chordotympany nerve, which passes more superiorly. It's all about the approach.
And this is where it gets really incredible with staphotomy. It's so delicate. The precision required is just astounding. The book tells you the distance from the footplate to the lenticular process of the incus is about 4.5 millimeters.
Yes, and that exact measurement is absolutely essential. It's for sizing the prosthesis correctly, and it dictates where you make the surgical opening. When you're fenestrating the stapes footplate, the procedure demands that the opening has to be in the posterior half of the footplate.
And that's a deliberate requirement.
It's deliberate to prevent the prosthesis from touching the saccule, which is a vestibular structure. If it touches, you're looking at significant vertigo or even sensory damage.
Okay, so let's shift from that microscopic work to the complex geography of the nasal cavity. The stakes change pretty dramatically here.
They really do. With rhinology and sinus surgery, you're navigating complex vascular supply and these paper-thin boundaries of the skull base and the orbit. So, starting with septoplasty, which is really a foundational procedure, the functional goal is simple: excise the excess deviated cartilage. But the structural warning is paramount. You have to maintain nasal tip support. You do that by making sure the anterior strut stays attached to the maxillary spine. And even more critically, the guide warns junior trainees to leave the keystone area, the osteocartilaginous junction, completely intact.
Because if you don't, that's when you see major problems.
Major problems.
Yeah.
Compromising that junction leads directly to saddle nosing, a dorsal collapse. It's a disaster.
And when you dive deeper into something like functional endoscopic sinus surgery, or SESS, the source material really stresses that pre-procedure diligence is it's non-negotiable.
Absolutely. CT scans not only have to be done, they have to be physically in the operating room for systematic, real-time review. Your anatomical landmarks are your absolute life jacket in SESS. So during an anterior ethmoidectomy, the guide offers this practical, almost unbelievable safety check.
Go on.
If you're not sure about the lateral wall integrity, the lamina papyracea, you can literally ballot the ipsilateral eye to confirm there's no movement.
Wow.
No movement means you haven't breached that paper-thin bone that separates the sinus from the orbital fat, and that means you've avoided potential blindness.
That is exactly the kind of practical tip that separates a textbook reader from an operative surgeon. Does that same caution apply to the deeper procedures, like a sphenoidotomy?
Absolutely. When you're widening the sphenoid ostium, you have to avoid straying too far inferiorly. It specifically warns you about the area where the septal branch of the sphenopalatine artery, the SPA, lies. Go too far down and you risk a major hemorrhage.
And speaking of hemorrhage, let's contrast the approaches for managing severe epistaxis, nosebleeds. You have the endoscopic SPA ligation versus the anterior ethmoidal artery, or AEA, ligation.
Right, and that AEA ligation often needs an external approach, a Lynch incision. It demands precise knowledge of the anterior cranial fossa's depth. The guide highlights the famous mnemonic, which is essential for localization and safety, the rule of 24-12-6.
And that rule tells you what exactly?
It gives you the relation between the anterior ethmoidal artery, the posterior ethmoidal artery, and the optic nerve. It provides critical depth measurements from the anterior lacrimal crest, acting as a mandatory depth gauge to protect the eye.
Okay, let's transition now to the real high-stakes head and neck surgery. We're talking major procedures where the integrity of vital nerves or the airway itself is threatened. Thyroidectomy seems like the classic example here.
It is. The whole procedure is about identifying the key structures: the recurrent laryngeal nerve, the RLN, the nerve of voice. It's best identified low down in a very specific landmark called Baer's triangle.
Wait, okay, if we're going to rely on that triangle for safety, what are its specific boundaries?
It's critically important. That triangle is bounded by the recurrent laryngeal nerve itself, the inferior thyroid artery, or ITA, and the common carotid artery, the CCA. Knowing those three borders cold is foundational, and then identifying the external branch of the superior laryngeal nerve, the EBSLN, that takes real vigilance. The guidance is to confirm its position with a nerve stimulator because its course is just so variable between patients.
And for preserving long-term function, like, say, regulating calcium, the goal is crucial there too.
Absolutely. Extracapsular dissection is mandated. That's for preserving the blood supply to the parathyroid glands and avoiding a life-threatening postoperative hypocalcemia.
So shifting to the airway, something like a tracheostomy procedure carries immediate life-saving risks.
It does. The standard adult elective fenestration site is between the second and third tracheal rings. But the most crucial safety tip, and this is to avoid catastrophic tube dislodgement, which can quickly lead to hypoxia, is the use of stay sutures.
Stay sutures, how do those work?
Well, these sutures are placed between the tracheal window and the skin. They ensure you have this unrestricted guided access for reinsertion, just in case the tube accidentally comes out.
That's a genius application of a simple technique for a life or death situation. Okay, finally, let's look at external carotid artery ligation, usually an emergency procedure for massive hemorrhage.
And the guide is emphatic. There's an absolute requirement for confirmation of the vessel before you litigate. You must identify the superior thyroid artery branching off the external carotid, and preferably the first two branches, to be absolutely certain you are ligating the correct vessel.
And not the internal carotid.
And not the internal carotid artery, which of course supplies the brain. That procedural rigor really underscores the enormous responsibility involved.
Let's round out the discussion then with a look at some diagnostic procedures and the principles guiding facial plastics. In diagnostic endoscopy, I'm guessing positioning is everything.
It absolutely dictates success and safety. For procedures like a direct laryngoscopy and bronchoscopy, the position is called sniffing the morning air. So, head extended, neck flexed. But for a direct esophagoscopy, you need maximum neck extension. We call it the sword swallower's position, to straighten out the cervical esophagus.
And there's a safety tip for DL, for direct laryngoscopy.
A crucial one. Always use the thumb of your non-dominant hand under the scope to lever against the teeth. It prevents damage to the patient's dentition.
Okay, and moving to biopsies, like fine needle aspiration cytology or FNAC, what's the tip there?
It's all about yield. You have to sample the tissue by moving the needle tip around just a few millimeters within the mass, all while the plunger is fully withdrawn. That's how you capture a good cellular sample.
And for an open lymph node biopsy?
The focus shifts to preserving the tissue quality for the pathologist. The key is to avoid handling the tissue directly. Use non-toothed forceps, or only handle the capsule to preserve that cellular architecture.
And finally, in facial plastics, whether you're planning local flaps like a Z-plasty, an advancement flap, or a bilobe flap, the guiding principle is always the same.
It is. For minimizing scarring, it's the strict use of relaxed skin tension lines, or RSTLs, to orient your incisions.
And we see some pretty unique techniques in the cosmetic procedures as well.
We do. For pinoplasty, or ear correction, the guide details the mustard technique. It requires tattooing the planned cartilage convexity, that's the superior crus and scuffa, before you score or suture it.
Tattooing.
It's done very precisely, using a 16-gauge needle that's been soaked in methylene blue to mark the lines for folding.
And lastly, for blepharoplasty, so eyelid surgery. The safety margins there must be critical.
Critical to avoiding just devastating functional and cosmetic outcomes, the guide warns that for the upper eyelid, you have to leave at least 2.5 centimeters of intact skin between the brow and the eyelashes.
That's a very specific margin.
It is, and for the lower eyelid, the warning is even more conservative. You only excise a minimal amount of skin to avoid the feared complication of ectropion, where the eyelid turns outward.
And that's a devastating outcome.
It really is, because it causes corneal exposure, chronic irritation, and it requires complex corrective surgery to fix.
Wow. We have covered an enormous breadth of procedures here, from microscopic ear operations to major neurovascular head and neck dissections and delicate facial reconstruction.
Right.
The level of detail required for a junior trainee is just immense.
It is. It demands total anatomical fluency. So, you know what? Let's test that fluency with a quick review exercise. Let's tie together the knowledge we just discussed in that high-stakes segment.
Perfect. Okay, so a patient undergoes a complex neck dissection and later on requires a thyroidectomy. The surgeon needs to locate the recurrent laryngeal nerve, the RLM, in the surgical bed, low down in the neck. So based on this procedural guide, what three structures form the boundaries of that key anatomical triangle used to reliably locate the RLN?
Right. That landmark is Baer's triangle. And the three structures you absolutely must identify and trace are the recurrent laryngeal nerve, the inferior thyroid artery, and the common carotid artery. You have to know those precise coordinates before you proceed.
That knowledge is the absolute foundation of patient safety.
And if we connect this to the bigger picture, I think,
Well, I think the most critical part of an operative procedure isn't always the technical challenge of the final incision. It's the meticulous preparation. It's the respect for these highly specific anatomical landmarks, like attention to detail, from, understanding the consent table risks to mastering the precise location of the marginal mandibular nerve, or knowing that 24-12-6 rule that preparation is what dictates success, not speed.
That's a profound thought for any learner embarking on surgical training. Preparation over speed. Always. Thank you so much for guiding us through this incredibly detailed operative deep dive.
My pleasure.
And thank you for listening. Until next time, keep digging deeper.